Hi, Catherine. The speakers, none of them worked. And then we were told that they worked with like E. coli and a bunch of other stuff, and then they would have cleaned a little bit better if they know people would be using it. Hi, good morning.
Hello.
Yes, fun technical issues on our end this morning, but we got them figured out. So.
Okay, awesome. Should I be prepared to share my screen?
Let me make you a co-host.
Okay, and I just put the link to the document for the breakout group in the chat. And Reagan, you're the one admitting people, right?
Correct. And then once it starts, I'll turn off.
Okay, I'm going to go ahead and share my screen and get that up and going.
You'll have to share the link again as people join because it won't show up for people that newly join.
Oh, gotcha. Okay. That sounds good. So Sasha, I'll share it once I'm done talking and hand off to you. I'll share it again. Okay, let me get my screen shared. Okay. Okay, can you guys see my screen? And is it only the PowerPoint that you see?
The PowerPoint is in edit view.
Yep. Okay, there we go. Reagan, you said that you were going to share your cell phone with us in case we had questions throughout. I didn't see it anywhere. I wonder if you could share that.
Sure. So it's 402-984-7945.
Okay, great. Thank you.
And I will do, when it's time for breakout sessions, random groupings of 6 to 8 people, depending on the size of the
Okay.
group.
Okay. Okay, and everything is going. Okay. Yep.
Just one question that I didn't write down in our planning meeting, but what time should I aim to cut off after the small breakouts so that we can pass it off to Alethia and Susanna, your wrap up? Like, how much time should we leave at the end for that?
Let me look and see. Are you guys seeing my, are you only seeing the PowerPoint right now? I just want to make sure you see. Okay. Yeah. I think we allotted, let me look at the abstract. I think we allotted 20 minutes. Let me just look at it. It's in the abstract.
Okay, we'll just aim to wrap up the breakout.
Yeah, yeah.
11, no, what time is it? 10, or you know what I mean.
Yes, these times are hard. Let's just see. Yeah, Sasha, you and I have 45 minutes total, so. And then we have, we need 15 minutes for Karen's and then 15 minutes for wrap up. So we have a half hour for Alethia's, Karen's presentation and wrap up.
You
Okay,
had
so
15 for me too, Kathy, right in the front.
Yeah, yep. Yes, 15 for you.
is it Karen or is it?
It's Alethia.
Alethia, yeah, okay. Just wanted to clarify.
Yes.
I wonder if she had trouble getting in, if she knows. Oh, she's coming late.
She's coming later. She's going to join midway. And I did reach out, so
I
hopefully,
remembered. I forgot.
yeah.
Oops, can you guys hear us?
Yes.
Okay.
Okay, we're on lots of tech problems over here. Okay, perfect. And when we start admitting people, I am gonna be just muted off video and I will let you guys handle it from there. Does that sound good?
Sounds great.
Sounds great.
And I'm happy to welcome everybody.
Awesome. Okay, do we feel good? Everyone has my cell number. You can also direct chat me or Carol. We're in the same room together, so either one of us. And we'll obviously be here, so you can also verbally ask for anything that you need and we'll be here. But I will go ahead and start letting people in if everyone's good with that.
Sounds great.
Thanks, guys.
Good morning, everybody. I see our room is filling up. That's great news. I'll probably give us about 30 more seconds just to see if the technology needs some room to breathe to make sure we all get in here. We've already gotten our technology glitches out of the way for the day, so there will be no more. That's my hope. We can go ahead and get started. Thank you, Kathy, for getting the slides up and ready to go. Good morning, everyone, and thank you for joining us today. I'm really glad to see those of you who decided addressing root causes through fatality review would be a good use of your time this morning. My name is Susanna Joy, and I'm a project coordinator at the National Center for Fatality Review and Prevention. We are the federally funded resource center that supports child death review and fetal and infant mortality review programs across the country. Throughout this presentation, we'll refer to those programs as CDR and FEMR. I'm joining you today from mid-Michigan, where the National Center sits within the Michigan Public Health Institute. And I'm going to start by just giving you a little overview of this session for you. First, I will be providing an overview of CDR and FEMR, sort of a fatality review 101. Then I'm going to hand it over to colleagues from FEMR and CDR out in the field, local and state programs, to share some of the ways that fatality review teams across the country have been coming together to address health equity and focus on some of the things that are commonly identified as problems by fatality review teams, as well as some solutions that they're finding to address these barriers. Then we're going to break into small groups and dissect some of these equity problems together that teams have identified, work through a case review scenario and reflect on those experiences together. We'll come back, share some discussion, and enjoy a presentation on the use of vitality-focused reviews to support maternal mortality reduction efforts in the city of Detroit. And then we'll have a chance to pose questions to our presenter panel. Next slide, please, Kathy. Before we get started today, I would be remiss if I did not acknowledge the generous funding that makes our work possible. And the National Center is funded in part through a cooperative agreement with the Maternal Child Health Bureau at the Health Resources and Services Administration. We are very grateful for their support and their partnership, but the contents of the presentations today are the sole responsibility of the authors. Next slide, please. So let's dive in. First, I would like to introduce or summarize the two processes we'll be discussing in the first half of today's presentation. Both are multidisciplinary case reviews that are meant to seek systems level solutions and not place blame on any individual, any agency, or any particular choice. In both of these processes, CDR and FEMR, fatality review teams review the story of a child's death, the context in which the child lived and died, and seeks to identify opportunities for systems level prevention. In both, case level data are collected and used to inform ongoing prevention efforts. So we'll start with child death review. CDR is a multidisciplinary case review. As I mentioned, they both are. It operates in all 50 states in the District of Columbia and within some Native American tribes. So altogether, we have about 1,350 teams across the country. Common members of CDR teams include, but are not limited to, child welfare, public health, law enforcement, emergency responders, pediatricians, injury prevention experts, schools, mental health providers, and other social services providers. Those are typical partners, but they do expand sometimes, particularly based on a particular case's needs. CDR developed sort of organically as a response to the undercounting and underreporting of child deaths that were related to child abuse and neglect. Some states have a review panel that sits at the state level and reviews cases, and others have local teams distributed across the state, often at the community level. States vary in their case selection criteria, but generally deaths are reviewed from birth through the age of 18. Commonly, these programs are led by public health agencies, child welfare agencies, occasionally by an attorney general's office or a medical examiner, and we even have a couple state programs that sit in a children's hospital. These prevention-focused death reviews rely on sharing records from community service agencies and providers to better understand the context in which a child lived and died, as well as the systems level response to the death. So moving over here to fetal and infant mortality review. FEMR teams are not quite as common as CDR teams. We have a little more than 150 teams right now in 27 states, and they are mostly at the local level. The majority of FEMRs sit within local maternal child health programs in communities with high infant mortality rates. And similarly, they're a multidisciplinary team, but the makeup looks a little different, as you'd imagine. It would include similarly child welfare, public health, law enforcement, and medical examiners are a partner in both contexts usually, but there will commonly be representatives from MCH services like WIC, other MCH programs like home visiting, prenatal care providers, maternal fetal medicine, perinatology, et cetera. So this really, it reflects the difference in the case selection criteria. FEMR teams will review stillbirths and infant deaths up through the first birthday. A few of the distinct characteristics of the FEMR model compared to CDR and other fatality review processes are that first, the FEMR conducts de-identified case reviews that rely on a case abstract of available records, and that abstract is created ahead of time with a summary provided to the case review team. FEMR attempts to include a family interview in the case review to elevate the lived experience of the family in the discussion, and FEMR is a two-tiered process. So there are really two teams. One team functions as a case review team, sort of doing that analytic function, diving in. But then they make recommendations that are then handed off to a community action team. And that community action team is tasked with implementing the prevention recommendations that come out of the case review. Next slide, Kathy. To just illustrate these briefly, here's a process map of what a CDR typically looks like. The cases are selected, team members are informed of the case that will be reviewed in an upcoming meeting. They access records at their agency level if they have any records related to services delivered to the family, the incident, or the response to the incident, and they bring those to the case review. The team reviews the case together. They make recommendations focusing on systems level improvements that could advance prevention. Case level data are collected and recommendations are used to catalyze prevention activities at ideally the local, state, and national level. Next slide, Kathy. You'll see that FEMA is just a bit different. The cases are selected. Records are requested instead of brought to review. They're requested from the different agencies, hospitals, providers, etc. A family interview is hopefully conducted, and those can be challenging to get. I'll just say it's an ideal piece of the model that they're included, and our teams do attempt to get them, but sometimes there are a lot of challenges to getting the interview conducted. But ideally, the data that are brought to that case summary come from the records and come from the interview. And then that's used to populate the de-identified case summary that is then shared with the case review team. The review is conducted by the case review team, and they make prevention recommendations to the community action team to support prevention at the local, state, and hopefully national levels. Thank you, Kathy. Next slide. One of the most important tasks of the fatality review team is to identify how observable individual risk factors that they see in the case reviews, particularly those that are reflecting the social determinants of health, such as maternal depression, child abuse or neglect, incarceration, individual housing instability, may be deeply rooted in community and systems level barriers like racism and poverty. As the technical assistance center for these programs, we get to see this done amazingly well by teams all over the country, and we get to help build capacity for teams to take this approach in their reviews. We do this by framing it in a couple different ways. First, as CDR and FEMA team members and representatives of community systems, participants really aren't in the position to make individual choices for families, for parents, or for their kids, but they are in a position to examine these systems together closely, and they're well positioned to help improve the systems that surround the families in their jurisdictions. Next slide, Kathy. The other way we frame this is simply by talking about impact. We want to prevent as many deaths as possible. And we know that across the causes of death, all the way from stillbirth through our teens that die, that there are shared risk factors and shared protective factors across all of those cases. There are certainly distinct risk factors around specific kinds of death, but when we can focus teams on those profound shared risk factors and systems level barriers, we really get to the root of the many individual risk factors that we see. We see teams addressing risk at multiple levels of the health impact pyramid that you'll see here, definitely through education and clinical interventions, but we also see them pushing their communities to move further down the health impact pyramid to address systems level risk. It's really a privilege for us to get to see them do that work, because often what we find is that the fatality review program is a champion of work to address social determinants of health and advance equity in their jurisdictions. And I really just think that one of the reasons that they do champion this work is because they really regularly see the concrete ways that the lack of equity plays out in the community very profoundly in their case review context. Next slide, Kathy. Before I wrap up, I would be negligent not to highlight one of the best tools we have for identifying risks and disparities in CDR and FEMA, and better understanding the burden of mortality in our communities, especially at an MCH epidemiology conference, I guess. We're grateful to be the hosts of the National Fatality Review Case Reporting System. This is the standardized data collection system for CDR and FEMA that has been funded by HRSA. There are currently 16 years worth of data in the case reporting system with over 200,000 individual case reviews in the system at this time. We have 47 and hopefully soon to be 48 states contributing and participating in the case reporting system. While it is far too expansive for me to go into today, it provides something that we call standardized reports for users, so they can click a couple buttons and they can get their case data kicked back to them and analyzed. It's not perfect, but it's particularly helpful for teams that may not have robust EPI support, or for just an initial exploration of the data, even if they do. I think we have over 30 standardized reports built into the case reporting system, focusing on all kinds of things: the child, the family, demographics, risk, and a broad range of psychosocial risk factors. These data are available to researchers through requests submitted to our data dissemination committee. So if that is of interest to you, feel free to reach out to me personally, either through the City Match portal. You can send me a message, or even here in the chat, and I can get back to you with that information. Next slide, please. Before I hand it to Kathy and Sasha, I really want to highlight potential audiences for these data in the states and at the national level. This is really what it's all about, is being able to share our findings and our prevention recommendations broadly. Obviously, community service agencies, public health agencies have a lot to learn from these case reviews that examine how the systems interacted with families. They use these data to inform prevention and program planning. Policymakers are a key audience for fatality review data, as fatality review can illustrate ways that the families and community are directly impacted by economic and policy decisions. And finally, the public, the communities themselves. It's really important for them to know that their tragedies do not go unanswered, that there are committed professionals led by public health who invest time and care to learn lessons from these really sad cases, and hopefully make their communities safer, healthier, and more just. So with that, I'll hand it off to my colleagues.
Thank you, Sasha. Thank you, Susanna. I'm going to start out and then hand it over to Sasha. Sasha and I have been working with the Fatality Review Center and many of our colleagues across the country, really digging into how to best use and leverage this incredible power that, that Susanna talked about within these teams and this review process, to really shed light on local and state gaps that are related to disparities, racial disparities, socioeconomic disparities, gender disparities, in an effort to really address the systems level and root cause of that. Sasha and I bring very different perspectives to this. I bring more of a local perspective. I operate out of the medical school, our local medical school, and partner with the public health department in running our local FEMA. And Sasha, I'll let her introduce herself when she comes on later, but I want to highlight that she operates at the state level and really focuses on the child death review, but bringing it the state and policy perspective to that. So I want to start out by just talking about the work that's been done at the national level to identify the health equity opportunities within these fatality review teams. And so I want to give a little bit of backdrop before digging into the work of our most recent Learning Collaborative. We started out in 2016, and then in 2017 and 2018, worked with to develop the educational resources and generated a guidance for how bringing equity into fatality review. We conducted survey with fatality reviews, child as well as FEMA fatality reviews, to identify some of the equity challenges that they encountered and some of their solutions, and then shared that through our work groups. In 2020, beginning in 2020 is when the first year of our learning collaborative, where we wanted to focus on, we worked together to focus on translating these equity tools and data that we had developed the first 3 years with our national and our peers across the US. And we wanted to translate that into practical usage. We wanted to identify the barriers and some of the potential solutions that teams were using and share that in a learning collaborative framework. This year, we have taken that and wanted to take it to the next application level. And we've been simulating, we meet quarterly, we simulate review team scenarios and practice applying some of the solutions that we've identified. We started out by focusing on 4 primary barriers and primary problems, and we dedicate each of our quarterly meetings to one of those, including victim blaming, and I'm going to talk a little bit more about each of those problems that we've identified, and then Sasha will talk about some of the potential solutions before we move into our own breakout session that again will simulate and be modeled from this learning collaborative that has been so effective in sharing our expertise. So what I want to do is to talk a little bit about how we have identified within fatality reviews. It was really helpful in year 1 of our collaborative to organize ourselves in examining equity by activity domains. And we identified domains that were common across various fatality review teams, maternal, child, and fetal infant mortality review teams. And these activity domains fell into these several areas that began with convening the team to begin with. Who do you invite? What is the format of the meeting itself? How do you bring stakeholders to it? The accessing records, which is compiling the case information, getting access to the information, including the family interviews in some cases. Reviewing the case itself. How do you run the meeting in a way that identifies and creates opportunities to identify equity? Not just who you have in the meeting, but how you are operating and how you're pulling in voices from various stakeholders as well as the community. Making findings is a really important activity that happens within these review teams. How do we draw conclusions about what those problems are? What are the gaps that we've identified? And then how do we translate that and prioritize writing recommendations about which gap do we prioritize? Which intervention do we want to recommend? What is the scope of the recommendations and what outcomes are we looking for? And then finally, moving into action. How do we take these recommendations, the FEMA findings and the review team findings and recommendations, and not just disseminate them, but partner with our local and state stakeholders to take action at the policy level, at the program level, at the process level within our partner institutions. So those are kind of the domains that we organized ourselves into to identify the various equity problems that were specific. And then what we did in year 2 is we took all of the expertise and we identified some of the common equity problems that really were seen across all activity domains, and that really came to that was something that was experienced by multiple fatality review teams. And so I want to talk a little bit and explain a little bit about each of these sort of 4, top equity problems that we had identified. And then I'm going to hand it off to Sasha to talk about the solutions that were generated from our colleagues across the country in our learning collaborative. So the very first one that we talk about is, and this is really common, is the victim blaming that can happen within the fatality review team itself. That review teams can sometimes focus too much on individual behaviors without taking into account the social context and circumstances that have led to some of these behaviors. And these are behaviors not just on the part of the families, but also on the part of the frontline and the stakeholders and the providers themselves. Another common equity problem that teams run into is this focusing on downstream, at the immediate action and circumstance that preceded a bad outcome. For example, bringing the baby into bed in an unsafe sleep death. And instead of focusing on the circumstances and the sequence of actions and circumstances that have led to this putting the baby in the bed, for example. The approach of focusing on downstream rather than upstream causes really doesn't leave a lot of room for prevention or intervention. Things like longer term maternal and paternal leave or respite childcare when you've got really fatigued parents, which often the problem leading to. There's usually circumstances behind the circumstances behind the circumstances. So how do we get to those upstream? Another common equity problem that teams run into is generating recommendations. Fatality review teams generate multiple recommendations for every single case they review, and often review dozens and dozens of cases over the course of a single year. Teams and stakeholders often have the capacity to run the review teams and to gather the information and hold the teams. It is really hard, though, to take those recommendations and synthesize them down and prioritize them. And depending on which ones are prioritized, sometimes the easiest ones, the simplest ones are the ones that get, action is taken on, but those aren't necessarily getting at those root causes. So how do teams make sure that they're generating recommendations and prioritizing across those different levels that Susanna talked about, so that we have real impact across multiple spaces and levels? Finally, a problem that fatality review teams is this action. How do we translate those recommendations and those findings into action? What is the role of the review team, and how do we create partnerships that actually have impact? Fatality review teams vary widely regarding their role in translating findings into action. Some teams focus on disseminating recommendations that others can then act on. Other teams are in a position to actually lead some of the programming and policy changes themselves. Regardless, this action piece presents a lot of challenges to teams. At this point, having sort of identified these challenges, I want to hand it over to my colleague, Sasha, who's been really critical in helping us identify and the solutions that come from this. So Sasha, if you want to take over from here.
Thanks, Kathy. And thanks, Susanna, for introducing the session. As Kathy mentioned, I am an epidemiologist who helps coordinate our child death review program in Colorado. So I have a more state level perspective on this process. And I've had the honor of co-leading our learning collaborative with Kathy over the last couple of years. I'm going to go through each of the common equity problems that Kathy described and share a few solutions and strategies that the learning collaborative identified. But I just want to preface that by saying these are not an exhaustive list. There's certainly additional strategies that we're not going to mention explicitly here today. So just keep that in mind. I'm also going to be fairly brief because we want to make sure that you have enough time in your breakout rooms to really dig in further to a handful of these strategies. So without further ado, I'm going to talk first about our victim blaming common equity problem that rose to the top. And some of the potential solutions are, of course, making sure that we're able to get that family or survivor interview that Susanna talked about, that is really common in the FEMA program, but can be incredibly challenging to actually get a hold of. That's really just such a gold standard, because being able to hear directly from the family or surviving members of the young person that died is just such a great way to hear from them the stressors that the family might have been experiencing that led to the tragedy. We also hope to include community members, young people, and family advocates on local teams, making sure that those folks are at the table when case reviews are happening. This is such a great way to share power and space, and is a great alternative, or in addition to having the family or survivor interview, because again, those folks who lived in the same community, young people who may have gone to school with a young person that died at the table can also shed light on some of those stressors that folks in that community specifically are experiencing. We want to make sure that we incorporate a strengths-based, resilience-focused approach to our discussions during the case review. It's also incredibly helpful to make sure we train our meeting facilitators and the team coordinators to identify and diffuse any hurtful comments. If a member of the review team, which again, as a reminder, as Susanna shared, is incredibly multidisciplinary. So at the table, you might have folks from the coroner office, from the local law enforcement agency, from human services. If anyone does make a harmful comment that is victim blaming or is blaming the family or is blaming someone who might have been involved in the investigation or in the systems surrounding that family, we want to make sure that the facilitator of that review meeting has the skills necessary to try to diffuse that comment and move the discussion more upstream. And then lastly, again, on the training piece, we want to make sure that teams and coordinators have training on implicit bias and intergenerational ACEs so that, again, folks really have that equity-centered mind when they're conducting case reviews. Next slide, please. The next one that Kathy mentioned is how so many teams tend to really pigeonhole themselves in a downstream focus rather than really having that upstream prevention discussion when they're reviewing cases. So a few strategies that we've identified include making sure that we can consider and reference the neighborhood context. So a few examples are the March of Dimes Equity Locator and the City Health Dashboard. If you haven't visited, for instance, the City Health Dashboard, it's a great way to see indicators like if that community had access to green space or walkability, if they had access to healthy foods, also levels of neighborhood residential racial and ethnic segregation, and the levels of childhood poverty in that area. It's just a really great way to, again, center on those systems level social and economic factors. And then I would also really encourage folks to see what your state or locality has for neighborhood context. I know that in Colorado, we have some state specific resources that can sort of dig into neighborhood context at a more granular level. So just explore what's out there for you. The next strategy is make sure we're focusing on systems constraints and missed opportunities. So what were the gaps in the systems and services surrounding that family that we could address? Consider how to scale up protective factors that are identified at the individual level to the community level. There's a lot of examples of this, but one I'll throw out there just so that we understand this strategy is we know that connectedness at the individual level, so having access to supportive family members and trusted adults for a young person is so protective. And how can we scale that up to a community level connectedness? Another solution is partnering with leaders from communities that face the structural inequities to inform the findings and recommendations that are made by the review team. Again, this goes back to having that family or survivor interview and having family advocates and community members at the table. That is a great way to make sure that we're considering the inequities that this young person and family face so that that can be incorporated into recommendations. Another strategy is making sure that we're making our findings and recommendations at multiple levels. So Susanna talked about how we really strive to have recommendations at the local, state, and national level. Another example is that health impact pyramid, different types of levels. So making sure that we're going down to that social and economic base of the pyramid. And then lastly, the case reporting system that Susanna mentioned in the last year, or I guess it's been about a year and a half, added a life stressors and strengths section to the case reporting system. And that includes many stressors that I won't mention all of them, but some of them are social and economic factors, like if the young person, their family, or their community had experienced racism or discrimination or housing instability and food insecurity. And I know that in my experience in Colorado at the child death reviews, this section has really been a way to prompt conversation around these upstream factors. And as we know, as many in the room are probably epidemiologists, this is also going to be a fantastic way for us to understand what these life stressors look like aggregated at a state and national level. Next slide, please. Another one of our common equity problems is that we have more recommendations than resources. It's so common for a lot of case reviews to end up with 10, 20, 30 recommendations, all at different levels. But do we have the resources to implement all of those recommendations? So what do we do? Some of the solutions are to establish a criteria to prioritize recommendations. This can be any number of things, but one example is, and there's a effort impact matrix that some of you might dig into a little bit in our breakout rooms. We also want to make sure that we're using data to identify trends in deaths and recommendations. We want to disaggregate the data by factors like race and income to identify problems that systematically impact certain groups. We want to make sure that we elicit community input on our priorities. We really want to have that community voice and recommendations. We want to prioritize recommendations that address multiple issues. So what are those shared risk or protective factors that we can implement a recommendation that might impact child and youth suicide, but it might also impact unintentional drug overdoses, among many other outcomes that we care about. And then we want to partner with local teams with a state team if that's possible in your jurisdiction, so that you can have data assistance and elevate recommendations to legislators and policymakers. And last but not least, next slide. So lastly, this is the motivating action piece. That's really hard for a lot of states, including Colorado. Some of the potential solutions are to disseminate our trend data, findings, and recommendations to other local and state groups so that they can use them and that they can elevate recommendations and take action if they would like. Again, here's that couple data with community voice so that we can create a compelling narrative and really do prioritize the recommendations and move them into action that the community wants to see happen. We want to reference equity-based strategies and their evidence. So this can be a variety of things, but one example is the Black Mamas Matter Toolkit. And if you haven't seen that before, definitely give it a Google. It's a great resource. We want to partner with existing groups and change agents to develop action plans. So this can be other community organizations who really do the work that your recommendations are asking for. So making sure that you have authentic and trusting relationships with organizations in your state or your community that can take action. And then lastly, create joint recommendations with other review teams. One example of this, at least in Colorado, is our child death review program is situated within our Department of Public Health and Environment, but we partner with the child fatality review team that also sits in our Department of Human Services. And every year we create joint recommendations, and just having that increased leverage on a recommendation can move it further. So that's just one example. I just want to take a pause there before we move into small breakouts and see if anyone has any questions about anything that Susanna or Kathy or I just presented. Feel free to take yourself off mute. You can always chat it in too. Okay, next slide, Kathy. So we're going to take some time now to do some small breakouts. We're going to randomly send everyone into groups of about 6 to 8 folks. And Kathy just chatted in a link to a document that has a case scenario that we would like everyone to read through. And then there is many discussion questions in there, but there's some instructions that include the 3 common equity problems that we want you to focus on are the victim blaming, the downstream focus, and the so many recommendations, so few resources. So as a group, you'll choose one of those and then scroll on that document to find the set of discussion questions that that go along with that problem. And then you'll just spend your time talking about those questions and then just come back to a larger group and just be prepared to share out a few of the key points that you discussed. Am I forgetting anything, Kathy or Susanna, before we go into small breakouts?
I don't think so. I think you got it. And I was able to open the link, so I think everything's working.
Yep,
Okay,
I think we're good to go.
wonderful. Well, we will give folks about 20 minutes in small breakouts, so just keep that in mind. But Regan, if you would like to send folks to rooms, that would be amazing. Thanks, everyone. I hope that your breakout room session was as great as the one that I was in. Kathy, we're seeing the back end of your computer. Oh, you know that. Regan, can you tell me how many groups there were?
Sorry, there were 3 groups.
Okay, so we just have like a few minutes to do a quick share out of what folks talked about. I will start us off for group 1. We chose to talk about the victim and family blaming topic. And a few really key things that we talked about were, of course, the factors related to the case scenario that were outside the control of the family, were, you know, the mother's work schedule, and therefore not being able to schedule home visiting appointments, having not having access to affordable housing, not having the childcare options that she needed, among other things. And so we really talked about how some of the strategies could produce recommendations like better connection for people to the services that they need. Jeffrey and our group really talked about how a lot of times services and resources exist, but getting folks who need it connected to those resources is the gap. We also talked about, for the case reviews itself and preventing victim and family blaming, a lot of folks in our breakout talked about how they do group norms and agreements and make sure that that's an active and collaborative process with the folks at their review team, so that they are all on the same page about how the purpose of the review is not to place blame, it's to really find those systems level prevention recommendations to prevent future deaths. I also really liked Hannah from Wisconsin shared that when they facilitate case review meetings, if someone recommends a prevention strategy that is at an individual or patient level, they really use that space to challenge that on the spot and say, well, what are some upstream ways that we can achieve that result? So I really liked that too. Is someone from the second group want to just take maybe 30 seconds to a minute to share your key takeaways?
This is Kathy, and I was in the second group, but it was a really good discussion. I'm happy to summarize, but I also happy to share with and have anyone from my group, Lisa, Ashley, Camelia, Michelle, or Moira. If any of you want to share, I'm going to pause for a moment and let you do that. But I'm also happy to summarize as well. So I'm going to pause. Let you speak.
This is Lisa. I shared that as an interviewer, it's very difficult to, it's hard when people make assumptions about situations and, you know, try and as they were referred to in the narrative that, you know, that they were blaming the family. I think that assumptions are just as bad as blaming, and that assuming that if something had been done, that things would have been better. There's so many underlying things, as they showed earlier in that graphic, in the root of the tree that you can't see and you can't fix. And we sometimes have to just accept the fact that there are things that happen in people's lives, and we can make recommendations to try to prevent them in the future. But a lot of times we can't fix things.
Thanks, Lisa.
Yep, and that really resonated with Lisa's comments around assumptions, really resonated with everybody in the group. Michelle shared, Michelle, I don't know if you want to share you had some amazing tools in Texas that you guys are using that I think the larger group would be interested in getting a quick summary of, if you're comfortable sharing those.
Can you hear me now?
Yep.
Okay. I was having the same issue. I was about, and I was like, wait, I'm not. Yeah, so we implement two kind of additional tools for our maternal mortality and morbidity review committee. We have a sociospatial context dashboard in which we worked with our review committee on what they kind of wanted to know about the community that she came from. And so based on that, we created probably about 20 to 30 indicators with graphics where we look at the environment that she came from and then compare it to Texas, and then where we can the US as well, so that they can get an idea of the environment that she came from. And then also we are right now doing a pilot with about, I want to say about 7 other states. We created a what's called the DASH tool, which is a facilitated discussion guide around discrimination and the social determinants of health. So we can be more responsive to the one question on our review forms as it relates to discrimination, and taking just a closer look at kind of that arena on each case.
Thanks, Michelle. And Ashley had talked about, she's an epidemiologist in the maternal mortality, and just they're trying to work on standardizing, developing standardizing the information they abstract and discuss. Camelia elevated that the family's immediate circumstances and cultural factors are really important in understanding root cause. And Moira didn't get a chance to share, so I'm gonna just, Moira, if you have any comments, would love for you to share them. Otherwise, we'll move on to the next, and then move on to the next group. There you are. I see you're unmuted, Moira. Unfortunately, we can't hear you. Moira, I'm so sorry we can't hear you. Maybe you could add it in the chat, your comments in the chat to everyone. And Sasha, thank you for this opportunity.
Yep. While Moira, if you have anything, chatted in, but if the last group wants to take just a few seconds to share a few takeaways, that would be awesome.
I believe I don't know if I was the last group, but I was a group that hasn't gone yet. And I would just recommend that my team, if you have any things to add to what I say on your behalf, please put them in the chat. I want to make sure that we get onto Alethia's presentation. We looked at sort of the upstream factors versus downstream factors when it comes to examining case reviews. I want to point out that Emily shared a really awesome resource, which is a social determinants dashboard that they're using in maternal mortality review as a pilot in several states that we're looking into now. I've been hunting it down off to the side here, very cool. But I think the thing that we were discussing was this continue to ask why, going back, asking, well, why did this happen? Why did that happen? Why was this still the case? We think that, obviously social and economic factors were profoundly impacting the outcome in this case. And one of the really cool things that the document had, and I give full credit to our epidemiology partners, Sasha and Kathy, was the racial segregation map to really think about the ways in which racism may be at play in our case reviews. And I will put the link in here if I can find it. I'm looking for it now. I think Alethia asked, I'll look for it. But thank you. I don't want to keep us any longer, Sasha. I'm sorry to sort of truncate things.
That's okay. We are running a little late, but that is you know, it happens. So Alethia will send it to you, and thank you everyone for participating in the small groups. But we just have about 10 minutes left in our session, Alethia. So whatever you can fit in is wonderful.
Okay, thank you very much for the invitation to speak today. Sorry I had to do double duty and switch back at the end, but I'm really pleased to be here. I'm Alethia Carr, as Sasha said. I'm the Health Equity Lead Consultant for the Southeast Michigan Perinatal Quality Improvement Collaborative, which is located.
Alethia, can you hold on one second?
Sure.
I just want to ask that if you are listening in, if you would please mute yourselves. We have a lot of, we're having difficulty hearing our speaker.
Okay, thank you. I'm located in Michigan, specifically Detroit, and that's where our project is administered. I'm filling in for Karen Schrock. I will mention that my grandmother was a midwife in Valdosta, Georgia until the early 1960s, and I believe all people are entitled to optimal health. Next slide, please. Project Detroit Voices for Life is an initiative funded by the Merck Safer Childbirth Cities investment. It's part of their $500 million global initiative launched in 2018 to help create a world where no woman has to die while giving life. Next slide, please. Our work was funded this February as the second cohort of a 3-year grant to improve maternal health in Detroit based on locally identified needs. We're working to promote evidence-informed interventions in the effort, recognizing that we may have to use innovation in our work in order to identify changes needed in our system of perinatal care. Our grant was awarded to SimQuick, which convened 4 community partners. SimQuick is one of 9 perinatal quality improvement collaboratives in Michigan that's supported by our state health department, MCH area, designed to improve health equity in the perinatal health system. Our region includes 3 of Michigan's largest counties, Wayne, which is where Detroit is located, Oakland, and Macomb County. SimQuick started in 2015 and has a membership of about 50 perinatal agencies to improve perinatal care in the region. The partners that are involved in this project include the Detroit Health Department, which is really the entity that's establishing the maternal mortality and vitality review team. And they're also working to recruit and train storytellers, which is part of our initiative as well. We're also working with Black Mothers Breastfeeding Association, which is recruiting, training, and facilitating the employment of community-based doulas. Henry Ford Health System is another partner that's addressing implicit bias within its health system by offering training to all of the practitioners in their women's health area and identifying another health system that will do the same. And that curriculum is that they're working with is in collaboration with March of Dimes. And then our last partner is Focus Hope, a longstanding community-based organization that is collaborating on storytellers and identifying men to discuss approaches to better engage them in the perinatal system of care. Next slide, please. The goal of the maternal mortality vitality review team component is to promote systems change through innovation in the approach to analysis, translation, and application of maternal health data. We are doing this by being more inclusive of community and understanding the factors of vitality that allow some women in Detroit with complicated childbirth experiences to survive while others, too many, die. This includes promoting systems change and includes going beyond the analysis of deaths in the traditional way, as well as including women from the community on the review team who have recent experience with the perinatal system, and the other partners you see listed here, EMS, police, many of the agencies you may be familiar with. We're really looking to identify system gaps that need filling to create a perinatal care system in Detroit where avoidable deaths in women from childbirth do not happen. We want to use our expanded knowledge of those aspects to support maternal health in Detroit, to reshape the system into one of vitality, demonstrated by elimination of maternal mortality and severe morbidity. Next slide, please. The vitality component includes several areas. One, analyzing whether the woman's death was preventable. Secondly, engaging with the state of Michigan to identify state level changes that seems useful. We're actually working with our state's maternal mortality review committee to make that happen, and identifying women with conditions or morbidities that match the women who have died in Detroit to examine and understand the circumstances that led to her survival or vitality. Next slide. Some of the challenges that we've had are listed here during our 10 months experience. Maintaining engagement of key community partners, of course, the response to the COVID pandemic for both vaccination and infection care has affected availability and focus of systemic agency representatives. Some of the systems changes in already under-resourced partners, such as domestic violence and substance abuse and mental health providers, has been a challenge, as well as working with state agencies to avoid punitive actions against pregnant women that are looking for services to address substance use disorder or mental health needs. We also have experienced challenges related to developing effective messages to women to avoid preventable deaths, and getting our medical providers on board to provide more messages in their pre and postnatal, well child, and other visits, really working to promote vitality. And we see that being addressed over the time of this initiative. And then, of course, the COVID-related lifestyle changes. Next slide. Reasons for optimism, the federal attention with the most recent initiative introduced by Vice President Kamala Harris on Monday at the first ever White House Maternal Health Summit Day of Action, and the commitment to strengthen maternal health really is promising. We also, as I said, have support from the state health department for maternal health equity, and really health equity throughout the MCH area. The state is also very involved with us, both in our SimQuick leadership team and with they actually participate in the maternal mortality and vitality review team meetings. Because we're working to coordinate things. The city's review team is not looking to replace the state's efforts, but really to build on the information that's gathered for Detroit women that a maternal mortality that happens in Detroit, and it better explain the circumstances behind it and address those systemic issues that need to be addressed. And then the initial meetings of our MMVRT teams have opened eyes to possibilities of reducing disparities in maternal outcomes. We also have very committed local partners, and the city health department's leadership is committed to this effort. The next slide, please. I have a definition of vitality, the state of being strong and active, a term used to describe a person's ability to live, grow, and develop. And this is the goal in Detroit for mothers, babies, and families. And I'll end there. Thank you, and let's all promote vitality. Next slide. If Karen Schrock is the project coordinator for this initiative, and if you'd like more information, we've included her information here. Thank you. I think we have 3 minutes left.
Thank you so much, Alethia. That was great. I will send it to Susanna if you want to close out in the last couple minutes. You're muted.
I'm muted. I'm sorry that we didn't get a chance to take your questions. I would encourage you that if you want to touch base on any of this, to send Sasha, Kathy, or myself a message. The City Match portal would be happy to communicate with you further. It's a really, really important topic. We love the work we do. It is hard work. Those of you who are engaged in fatality review, thank you for the service that you're providing and the courage that you have to face these stories and to really dig deeply into them. It's been a privilege to talk with you all today and to join you today. And thank you for taking the time to listen to us share the work that's being done. Thank you, Sasha. Thank you, Alethia, and thank you, Kathy.